This educational PowerPoint is being presented in an effort to help you understand the differing protocols and interventions that we employ here at Bay Medical Sacred Heart and our Stroke Center of Excellence when caring for individuals who are either at risk for or who have suffered from a cerebrovascular event or a CVA. The objectives of this presentation are to define stroke, to discuss the differing signs and symptoms and the effect that stroke has on body systems. We will discuss the pathophysiology of the two major classifications of stroke and potential causes, as well as risk factors, both modifiable and non-modifiable, that contribute to the incidence of stroke. Lastly, we will discuss proper monitoring and documentation when caring for individuals who have been admitted with a diagnosis of CVA, TIA, or carotid stenosis. Stroke is the fourth leading cause of death in the United States. Every year, 795,000 individuals will suffer and die from a stroke in the United States. And stroke is the #1 cause of long-term disability. 1 in 4 of the individuals who suffer from stroke will have suffered from a stroke previously. In 2010, the estimated cost of medical care associated with stroke was $34 billion annually. This number is expected to continue to increase as our population ages and is living longer due to streamlined treatment strategies and improving quality of care. Stroke in itself is considered to be largely preventable through the modification of risk factors, assisting individuals with lifestyle changes, and through management of disease processes that contribute to stroke incidence. The early recognition and seeking of prompt medical treatment can lessen the degree of disability and the potential death that an individual can sustain. The definition of stroke is a sudden or acute loss of brain function from an alteration in the blood supply that is leading to or that is within the vessels within the brain. When the blood flow is altered, the brain is deprived of vital nutrients such as oxygen and glucose, resulting in ischemia and tissue death. Neurological signs and symptoms will vary greatly based on the size and the severity of the ischemia that's being experienced. Often there's a rapid onset of hemosensory deficits, although there are some cases that the symptoms can be progressive. Often you will see a hemiparesis or a quadriparesis, sudden visual disturbances or loss, speech difficulties, aphasia, slurring of words, or perhaps ataxia, vertigo, or a loss of balance and coordination. Some individuals may have a sudden decrease in their level of consciousness or complain of a severe headache. It's important to understand that there are differing disease processes that can sometimes mimic a stroke, such as alcoholic intoxication, cerebral infections, drug overdose, hypoglycemia, brain tumors, seizure disorders, and migraines. The area of ischemia that is being affected in the brain will often result in the symptomatology that we are seeing. For example, if an individual has a sudden alteration in their vision, they may be having an ischemic event in the occipital lobe. Because the cranial nerves cross and the brain is divided into the right and left hemispheres, often events that are occurring in the left hemisphere will display in right-sided deficits. We educate our patients that if they see any of these signs and symptoms, to seek prompt medical attention using the acronym FAST. F stands for face or facial asymmetry. A stands for arm or extremity deficits. S stands for speech or sudden difficulty understanding or speaking words. Explain to a patient at any time should these occur. It is time to call 911 and seek prompt medical treatment. There are two major classifications of stroke. They are ischemic and hemorrhagic. 85 to 87% of all strokes that occur are ischemic in nature, with the resulting 15% being hemorrhagic. When we consider ischemic strokes, there are two different types of events that occur, either thrombotic or embolic, in which the arteries that are leading to or that are within the brain have been occluded. Typically, a thrombotic event has occurred from the process of atherosclerosis. Atherosclerosis occurs when fatty deposits or lipoproteins collect along the lining of the vessel wall, building up, causing occlusion, and as time passes, these fatty deposits become hardened. They often can get cracks or fissures, and when this occurs, platelets aggregate at the area, forming an embolus, blocking the blood flow, thereby causing brain tissue death. An embolic event typically occurs from a blood clot that has broke off from a different location of the circulatory system, often from plaque buildup in the carotid arteries or by clot formations that have occurred in the atria from a condition known as atrial fibrillation. With hemorrhagic events, the artery breaks open or ruptures, causing blood to accumulate in the vital tissues that are surrounding the brain or that are within the brain, causing pressure to damage brain tissue and cause cell death. Often, aneurysms develop over time, and increased blood pressure contributes to the rupture of these vessels. The most common type of hemorrhagic event that occurs is a subarachnoid, and this occurs when a cerebral artery within the brain ruptures. An intracerebral stroke occurs when a vessel that is between the brain and the lining has ruptured and blood accumulates in this space, causing pressure on the brain, resulting in brain tissue death. It is important also to discuss a transischemic attack, or a TIA. Often a TIA is ischemic in nature. However, the blood supply to the brain is often only occluded for approximately 5 minutes, although a TIA event can last anywhere from 2 minutes to 24 hours. Often there is no lasting damage, but it is a serious warning sign. 10 to 15% of individuals who have suffered from a TIA will have a major event within a few months of suffering their initial TIA. Therefore, it is important to look at risk factors in all individuals, both TIA and with the different types of actual strokes, in order to prevent a recurrent or a more serious event from occurring. And so when we look at risk factors, there are some things that we are not able to treat, but they are important to consider, as these individuals need to be educated so that if a sign or symptom of a stroke occur, they know to seek immediate treatment. Of course, advancing age is the most prevalent non-modifiable risk factor, and that is simply because of the pathophysiological changes that occur with our vessels as we age. They thin, they become more fragile, as well as differing disease processes have had a longer time to affect the blood vessels that can contribute to rupture or atherosclerosis. Certainly, a family history of stroke will contribute to the incidence of stroke through hereditary genetic factors. Personal history of stroke, as we talked about earlier, is certainly a factor, in that 1 in every 4 strokes that occur are in individuals who have suffered from a previous stroke. And often that is because there are other disease processes, such as high cholesterol levels or hypertension, that are contributing to the incidence of stroke. When we consider gender, while stroke is more common in men than in women for most age groups, women are more likely to die from a stroke than men are. Part of that statistic may be that women have a longer lifespan than men, and women have a higher incidence of hemorrhagic strokes than men do. Hemorrhagic strokes have a higher mortality typically than ischemic strokes do, and therefore we can assume that is why more women tend to die than men. When considering ethnicity, Blacks, Hispanics, American Indians, and Alaska Natives all have a greater chance of having a stroke than do non-Hispanic whites or Asians. In fact, the risk of having a first stroke is nearly twice as high for Blacks than it is for whites. And Blacks are also more likely to die from a stroke than are whites. However, there have been recent studies that are very promising, showing that when we are able to aggressively manage disease and other risk factors, it can significantly reduce the risk based on ethnicity to become unilateral with Caucasian and Asian populations. When considering viable risk factors, the most prevalent risk factor that is present in all types of stroke is high blood pressure. High blood pressure often occurs but is silent in nature. And so high blood pressure is often considered a silent killer in that symptoms do not manifest often until damage has occurred. It's important to educate patients to monitor their blood pressure on a routine basis. Often, if the systolic blood pressure is over 140 or the diastolic blood pressure is over 90, on a consistent basis, we should notify the physician as well as educate our patients to notify their physicians for better blood pressure control. About 1 in 3 U.S. adults have high blood pressure, but only approximately half, or 52% of these people, have their high blood pressure under control. The other risk factor that we look at as well is a cholesterol level, or the LDL specifically. When the LDL is elevated over 100, the current best evidence guidelines state that a patient should be medicated with an anti-cholesterol medication called a statin. Statins can cause arthralgias and other problems, but if a patient is able to tolerate a statin medication, it is considered the best treatment for high cholesterol level. And this is to prevent the buildup, of course, of the lipoproteins that contribute to atherosclerosis. Atrial fibrillation is another prevalent risk factor in the incidence of ischemic strokes. Atrial fibrillation occurs when there is an asynchronous contraction of the atria. This causes a backflow of blood in the atria and can contribute to the development of tiny clots that can migrate through the major arteries to the cerebral arteries, occluding the smaller vessels in the brain, or an actual thrombus can occur on the wall of the atria, and a large clot can break off from that, causing occlusion in the carotid arteries, both internal and common. Diabetes can contribute as well to the development of atherosclerosis, or hardening of the arteries. Neurons require a constant supply of blood-rich oxygen and glucose. And so when a patient is displaying signs and symptoms of a stroke, one of the first things that we do is check a glucose level to rule out hypoglycemia. It's not uncommon to correct a hypoglycemic event and the neurological deficits to resolve. When discussing with patients their personal lifestyle risk factors, it is important to educate them about the contribution of a diet that is high in sodium, as it can cause high blood pressure, as well as high saturated fat diets contributing to atherosclerosis. Inactivity and obesity often go hand in hand. although inactivity can also contribute to the development of blood clots, which can cause an embolic event to occur. Smoking contributes to vasoconstriction. This, of course, reduces the oxygen flow to the brain, as well as smoking contributes to the development of the lipoproteins to deposit on the lining of the vessels. Smoking also contributes to blood clot formation and high blood pressure. Smoking affects every disease process that is listed as a risk factor for stroke. Therefore, if you have a patient that is admitted with the history of smoking, it is important to offer cessation counseling and medications. Illegal drug use is also a risk factor for stroke, and often those that have abused amphetamines such as cocaine can have ischemic events, as well as hemorrhagic events occur. Now that we have discussed the pathophysiology of strokes and how they occur, as well as some of the risk factors that contribute to stroke, we will discuss interventions that we employ when an individual comes into our emergency room or who displays the signs and symptoms of stroke once they have been admitted. Of course, the most important priority when an individual is admitted is to make sure that their vital signs and their airway are stabilized. Once the CABs have been managed and vital signs have been established, it is important to get an EKG to rule out any type of cardiovascular event. Rapid lab monitoring should be employed to assess for hypoglycemia, as well as to check coagulation and the CBC in case an individual is ruled in to receive TPA. An NIH scale should be immediately assessed on arrival to the ER in every individual who displays any signs or symptoms of a stroke. That should also be performed on admission to the ICU or to the med-surg floor. And this should be documented. If there is any change in the patient's level of consciousness or a decreasing status, an NIH scale should be reperformed and documented. Symptom onset should always be determined and documented, as we have a 3-hour window of symptom onset with which to administer TPA if the patient is having an ischemic event. Of course, to determine whether the patient is having an ischemic or a hemorrhagic event, the patient should go for a stat CT of the head without contrast to determine appropriate treatment. A patient should receive an exclusionary criteria filled out prior to any TPA administration, as there are certain disease processes as well as other risk factors that would preclude us giving TPA. If the individual is suffering from a hemorrhagic event, we of course would consult neurosurgery for any type of surgical intervention that would need to be performed. Before any oral medication is given, the nurse should perform a bedside swallow screen to determine the appropriateness of giving any oral medications prior to giving them. Often, a physician will prescribe an antiplatelet or an antithrombotic medication, such as an aspirin or a Plavix, and CMS requires us via the core measures to administer this within 48 hours of admission. It is important to determine the safety of administering these medications, and if a patient fails the bedside swallow screen, we are to keep them NPO and notify the physician for alternative therapy. If a patient has a risk for VTE, as well as for clots such as having atrial fibrillation, the patient will also be receiving anticoagulation meds such as heparin, Coumadin, Fragmin, etc. Based on the results of the patient's cholesterol and their history of hyperlipidemia, they may also be receiving a statin medication. Because of the neurological deficits that occur with stroke, such as hemiparesis, often we will order physical therapy, occupational therapy, or speech therapy, or all of the above for rehabilitation. Giving the patients the read educational stroke pamphlets, as well as discussing managing diabetes, hypertension, atrial fibrillation, discussing smoking cessation support groups, as well as the cardiac and stroke rehabilitation program, are all important factors to ensuring the success of preventing recurrence of stroke. There are several apps that individuals and their family members can download onto their smartphone that help them as well to time symptom onset should they occur again. The Joint Commission identified 3 major areas of improvement for our Stroke Center of Excellence. The first is to document the bedside swallow screen in every individual that comes in with a CVA prior to oral intake. This is documented in Paragon under the Daily Assessment or the Admission Assessment Stroke tab. We should also document every neurocheck and vital sign per the stroke program protocol and recommended guidelines in the Daily Assessment or the Admission Assessment Neuro tab. The other very important aspect that we need to focus on is the documentation of specific stroke risk factors when we give the patient written discharge education. Looking at the physician's history and physical and documenting the risk factors congruent with what the physician has documented is incredibly important to our success, as well as the patient understanding the risk factors that can contribute to the incidence of a recurrent event. In Paragon, the Stroke tab also houses the area to document the NIH stroke scale. If you click on the NIH stroke scale box, it will then open up so that you can document the NIH stroke scale. Again, this is done on admission as well as with any status change. Below the NIH stroke scale is the initial swallow screen assessment that should be filled out on every patient at admission and with any status change. In the Neuro tab of the daily and the admission stroke assessment, documenting swallowing without difficulty is not sufficient for a bedside nurse swallow screen. If the bedside nurse swallow screen has not been documented, please perform one before giving oral medications. As you follow the prompts to document the bedside nurse swallow evaluation, it is important to note that if a patient fails the screening, keep the patient NPO, notify the physician, and obtain a speech therapy consult. And get any medications that need to be administered changed to rectal, NG, or IV administration as needed. When you are documenting the neuro assessments, that can be done initially in the admission assessment neuro tab. But more frequently, of course, you are going to document these in the neuro assessment tab shown. Again, this is a screenshot of the NIH stroke scale when it is expanded. Perform it on arrival to the ER, ideally 1 hour after, to quantify any changes that have occurred. The NIH should be administered on admission and with any status change. The CMS requires us to monitor 8 different stroke core measures. Every ischemic and hemorrhagic stroke patient should receive VTE prophylaxis by midnight the day after hospital admission. This is accomplished through the documented application of SCDs and/or the administration of anticoagulation medication such as heparin, Fragmin, Coumadin, etc. Administering aspirin, Plavix, or other antiplatelet medications are not sufficient for VTE prophylaxis. IV thrombolytic therapy, or TPA, is initiated for any acutely ischemic stroke patient who presents within 3 hours or 180 minutes of the time that known stroke symptoms began. Of course, as discussed earlier, we would always perform exclusion criteria to rule out any contraindications for this treatment. Ischemic stroke patients, not hemorrhagic stroke patients, should have antithrombotic therapy such as aspirin or Plavix also administered by the end of hospital day 2. They should also be prescribed this antithrombotic therapy at discharge. Also, any ischemic stroke patients that have a history of or who have currently AFib or aflutter should be prescribed an anticoagulant at discharge. Ischemic TIA and carotid stenosis patients who have a cholesterol level, LDL, over 100 should be prescribed a statin medication at discharge. All stroke patients, TIA, rule out stroke, carotid stenosis, are given educational material at discharge. The nurse must document education and literature describing EMS activation if signs or symptoms of a stroke occur. You should specify the stroke risk factors in congruence with what the physician has documented in the history and physical, the warning signs and symptoms, any medication teaching such as anticoagulant therapy, aspirin therapy, etc., as well as discussing with the patient follow-up care and appointments. The discharge instruction form has areas that specifically detail these factors for you to check. Lastly, all stroke, TIA, and carotid stenosis patients should be assessed for rehab services, speech therapy, physical therapy, and occupational therapy. If rehab services are not ordered, often for TIA patients who have returned to baseline or carotid stenosis patients, it must be documented why rehab was not ordered by the physician. This concludes this presentation. If you have any questions, please notify the stroke coordinator or the quality department. And have a nice day.